everybody, thanks for a great evening yesterday, and here we go. I'm going to talk to you about critical care cardiology, past, present and future, as yesterday I have no conflicts. Okay, so if we're going to understand where the future is, we have to look backwards a little bit to understand where we've come from, otherwise we'll get things wrong. So a little bit of history, which I always think is great. So going back now to 1929, so nearly 100 years ago, this guy did the very first catheterization. He actually got fired from his job for doing this, which is probably not a great start in your career. Anyway, 1941, Cornand and Richards, they measured the cardiac output, and then in 1956, having been fired from his job, the guy shared the Nobel Prize for this great advancement in cardiovascular medicine. In 1958, Soames did the first coronary angiogram by accident, but he did do it. And Charles Dotter did the first angioplasty, albeit peripheral, and it was a rigid dilatation, but it was back in the 1960s. So now we get to the 1970s. So the 1970s were really interesting in the world. So this is what's happening in the 1970s. Concorde flew for the first time. You could get your first desktop computer in the 1970s. This company was formed, Apple. Saturday Night Fever was in the 1970s. Elvis Presley died. Diphtheria was identified for the first time. The WHO declared that smallpox had been eliminated from the world. Star Wars was launched in the 1970s, and the French guillotined the last person in Paris in the 1970s. That's the last time they used the guillotine as a mode of execution. So the 1970s were an extraordinary time. And in the 1970s, cardiology changed completely because of this guy, Grunsig. He undertook the first balloon angioplasty in man in 1974. He presented at the AHA, he presented PCI in dogs, and people laughed at him and said, this is a nonsense, it can't be a thing. Anyway, he came back the next year, and after doing the first awake, dual lumen coronary angioplasty, and he got a standing ovation. And Soames, who had been done the very first accidental one, he was in tears, he was so moved by this extraordinary advance. So 1970s thought to be a year that changed cardiovascular medicine, and things didn't stop there. So Ulrich Sigvart, I had a privilege to work with Ulrich Sigvart, an extraordinary man, he's a Swiss cardiologist. He invented a number of things. So he invented the femstop, he invented the wall stent, so the first self-expandable stent, so angioplasty became safe and predictable for the first time. And he also invented alcohol septal ablation for hypertrophic cardiomyopathy, so a truly extraordinary guy. Now PCI is the commonest intervention, and we're constantly evolving. So everything that we do now in the cath lab goes all the way back to those events back nearly 100 years ago. Every intervention we do, everything we do with EP, with valves, everything we do goes back to the catheter-based technology. So that's cardiology up to now. Critical care, what happened in critical care? Well, in 1971, this is a photograph taken by the great Bob Bartlett. They put the very first patient on ECMO. And really nothing much happened since then in critical care medicine. Sorry, Guido, but it's the truth. But things did begin to happen with respect to that interface between cardiology and critical care medicine. So going back to what Christian was talking about yesterday briefly, at European level we began to recognize that there may be critical care cardiology was a thing. The working group of acute cardiac care was founded. It eventually became an association. There's an examination, there's a subspecialization. Over the other side of the Atlantic, the Americans have begun to wake up to the fact that critical care cardiology is different from general cardiology. And they've started looking about how to train people, what track they should take. Should they be intensivists? Should they be cardiologists? We're beginning to see evidence that if you have a cardiologist in your cardiac ICU, your patients do better. And in particular, with patients with cardiogenic shock, your outcomes are better if you are dually trained, or at least your team are dually trained in both. And there are beginning to be questions asked about, well, if you're a cardiologist and you're going to be practicing this level, are you really sure that you're appropriately trained? Can you manage all of these aspects of critical care cardiology? and a beginning of understanding of the pathways, and I think Davor touched on this a little bit, of do you need to be an intensivist, do you need to be a cardiologist, can you be both? I think it doesn't matter so long as you have the skills. So now for the first time, critical care and cardiology are coming together, and all we have to decide is what kind of intensive care cardiologist we're going to be. So that's the past, that's the present. What about the future? So this is the fun bit. And when I look at the really, really depressing outcomes in cardiogenic shock, I turn my eyes to our, I would say, competitors in medicine, the people who deal with the next most common cause of death, and that's in cancer. And they have a very, very different attitude. So they test the patient and they test the tumour. They look at targeted immunotherapy, so using your own immune system to attack your cancer cells. They're looking now at real-time bespoke radiotherapy, where you sort of send out these search and destroy things that will find the cancer cells that haven't yet even been identified and kill them immediately. And they're looking at different ways of delivering even chemotherapy, so they now have pressurized intraperitoneal chemotherapy for patients with ascites. So the cancer world has really, really evolved. Meanwhile, back in cardiac intensive care with cardiogenic shock, we are stuck. And we're stuck because we're dealing too late with multi-organ failure. And we need to really start looking at prevention. We need to start thinking beyond just the heart. We need to look at cardiovascular and beyond. We heard about multi-organ system dysfunction yesterday. And we need to understand better the genomics, the proteomics, and the metabolomics. And I had the privilege to chair a session at the ESC for one of Christian Haseker's research fellows, looking at the metabolomics as predictors of outcome in patients who've had out-of-hospital cardiac arrest. So if we just begin to look differently, we might understand our patients a little bit better. I think for me, predicting decline is one of the greatest things that we need to do. We need to know which patients are going to get sick. So this is a still from the movie Monty Python and the Holy Grail. Okay, it's a great movie if you haven't seen it, but I think predicting decline for me is the Holy Grail of critical care cardiology. So at the moment what we do is we look at lactate and we look at liver dysfunction and renal dysfunction, and that tells us that something bad has happened. It would be like if you wanted to prevent a car accident, having a monitor or an alert system that can detect smoke and flames. It tells you that it's already happened. It doesn't tell you that it's going to happen. So what we need is the stuff that tells us that bad things are going to happen. What people talk about a lot is big data. So this is IGNARC. This is data that we can get from any patient in any intensive care unit anywhere in the UK. And they every month give us data and quality metrics on how we're doing. And people think that maybe if we look at machine learning and artificial intelligence, we can look at the correlation and we can predict what's going to happen. But there is a bit of a danger here. So this is a fantastic website. You can look at correlations, okay? So here is a beautiful curve showing correlation of number of people who drowned by falling into a swimming pool with the films that Nicolas Cage appeared in. Now, well, maybe there's not causation, I don't really know about that one, but there's this other one. This is per capita cheese consumption, but with number of people who died by becoming tangled in their bed sheets. Okay, so the worry is, if we look at big data, all we see is artificial correlations rather than causations. But I think it's a slightly naive thing, because artificial intelligence has moved way beyond what we're used to it. So this was a fantastic study where they took an artificial intelligence machine, AlphaZero. They told AlphaZero what the rules of chess were, and they told AlphaZero what winning looked like. That was it. They didn't tell AlphaZero anything else. And within hours, AlphaZero beat all of the world's best chess players. Understood the rules, understood where it was going to go. So artificial intelligence is an extraordinary thing. And then when you measure that, map that out with also wearable technology, or you can look at your innables, your outables, your wearables, then we could go somewhere really exciting with our patients in the future. So that's sort of artificial intelligence, machine learning. What about other things? So molecular imaging, I think, is a really interesting area. So to my mind, I think the heart is a bit of an innocent bystander in the disease that is atherosclerosis. So it's a very, very generalized disease. Yesterday we talked about acute myocardial infarction patients and how they're different from other patients with cardiogenic shock? For sure they are. And the heart for me is just an organ which is a very loud biomarker. It gives you chest pain, it gives you arrhythmias, and it causes you to die, but it's a sign of the bigger vascular information that you've got. And we're beginning to look at the vascular information that doesn't just look at cardiogenic shock, but it looks at the vascular information underpinning an acute myocardial infarction. And you can look at the vessels of the body, and you can take nanoparticles and you can image vascular information, and you can see where it is. So potentially in the future we could do a lot with that. And so I'm going to take you on a slightly strange journey now to talk about nanobots. So this is molecular particle imaging. Now, nanobots are extraordinary things. These guys won the Nobel Prize in 2016 for it. And these are biocompatible machines on a near nanoscale. So think about your vascular information, think about the organs that are being affected, and think about what you could do with these. And when they were launched, there was a thought that maybe we could use nanoparticles to take drugs to different parts of the body. And some guys, these guys, did an extraordinary experiment. And what they did was this. So they built some little nanobots. So these nanoparticles, it's like origami DNA. And they folded up this origami DNA. And within the origami DNA, they had these bits that could change configuration because they had iron oxide nanoparticles there. So you could open and close the doors depending on the electrical activity that the nanobots were subject to. And then inside the origami DNA, they put fluorescent particles attached to a particular molecule. So the nanobots, they then injected into cockroaches. You can see a picture of a cockroach here, which is fluorescing. So this is a cockroach that's got nanobots with all those little doors open, so you could get release of this fluorescent drug. But if you change the electrical signal around the cockroach, the doors would close and the cockroach would stop being fluorescent. Then what they did was they took people like you and me, and they made them wear an EEG hat, and they made them just read a book. So you're just reading and your brain's doing its normal thing. Then they made them do complex sums, and their EEG hat was attached to a computer. And the computer was attached to a coil within which was sitting the little cockroach with the nanobots going around and around. So somebody is reading a book, the cockroach is sitting in the coil, nothing is happening. Then they made them do complex sums. Complex sums, the EEG started firing massively. The computer recognized that. The coil changed the particle charges there, and the nanobot opened the doors and the cockroaches began to fluoresce. So just by the power of your mind, you can control the release of a drug in another living being. Extraordinary. Now you might think that was a crazy thing to do. The reason they did it was they thought that maybe in patients with, for example, epilepsy, where you have electrical activity in the brain, you could inject the drugs, anti-epileptic drugs, through nanobots, and then they would be only activated in the bit of the brain with the electrical activity. Or, for example, patients with schizophrenia. If they have higher electrical activity, it would avoid all the side effects of the peripheral drugs, but you would only get the drug delivered where you wanted it. So it's a fantastic experiment, a slightly crazy thing to do, but you kind of think, maybe this, the movie Fantastic Voyage, that's kind of exactly what they're beginning to do in real life now. If we look at what is already in development, so if you speak to your colleagues in the European Space Agency, you speak to people in NASA, you say, what are you actually up to? They're up to all of these things. So we already have things like the heart on the chip, so you can do your organometrics and organonomics. Cell therapy is already happening. The flexible sensor technology is extraordinary. Entanglement theory is becoming a reality. So if you take an atom and then you split your atom, and then the other part of the atom is 100 million miles away, you spin it one way, and then you turn the way it spins, the other one will absolutely at the same time spin in the other direction. So being able to do things very remotely, very, very quickly becomes a reality. And then of course we get into big data and your digital twin and virtual trials, that kind of thing. So all these things are already happening. So you might think that I'm completely mad in saying all of those things are going to be our medicine in the immediate future, but I'm going to take you back a little bit. So this is 1936. This is probably one of the best films. If you haven't seen it, you should definitely see it. It's a gangster movie. So this is 80 years ago. Boris Karloff plays the innocent victim in this. But there were some extraordinary predictions 80 years ago for what we now take as today. So the plot is this. So Boris Karloff is an innocent man, and there's a gangster heist that goes wrong, and the mob, they say this is the man that does it, and he's tried and he is executed. And conveniently next door there's a mad scientist who has an artificial heart. Now the artificial heart was first described the year before, and this thing was an external thing, but anyway, in the movie they internalize it, and here is the mad scientist, here is Boris Karloff, and he is receiving his artificial heart. So they predicted 80 years ago that we would use extracorporeal devices, that we would have an artificial heart, that we would be able to take people who have died out of hospital cardiac arrest, resuscitate them, eCPR, and even in the movie, Boris Karloff comes back, here he is coming to take his revenge with his artificial heart, and they predicted the risk of bleeding and stroke. So when you look at Boris Karloff in the movie, when he comes back, he has a hemiparesis, and you see them looking at a little X-ray of his brain where they can see the bleed. So 80 years ago, these guys predicted artificial heart, out-of-hospital cardiac arrest, eCPR, and the complications of it. Who'd have thought it in a Hollywood movie? So, what do I think about it? All of these techniques, these technologies, the nanobots, the artificial intelligence, the predicting decline, all of those are things that we have now. And in 80 years' time, I think we'll see them as completely routine. So I'd say the future we have, Christian, to you, is already here. Thank you.